Assalamu alaikum, everybody on board. Welcome on board. I'm sorry I just got late in something. Um, Before some more people join, any questions? Anyone wants to ask any question? The topic which I just want to discuss today is actually a journal discussion, and it is just to make your approach to face any critical incidents. Uh, by the way, what do you think? What can be the critical incidents inside OR? Anyone, please? Can you people hear me?
Yes.
Okay, so what may be the critical?
Anaphylaxis,
Okay, anaphylaxis. What else?
collapse,
I'm sorry.
cardiorespiratory collapse or arrest,
Okay, what else?
uh, drug toxicity, fluid
Okay,
overload,
okay,
hypoxia,
okay. What is the common factor? Like, what is usually the common end?
Massive bleeding, Doctor.
Yes, massive bleeding. So actually, usually the common end is affecting either, usually either the respiratory system or cardiovascular system or both, okay, or some neurological system. Usually, this is the end result, okay. So majority of the in majority of the complications, we will just try to have some examples. Like for example, if you have, if you were saying, if we just take one complication, for example, to start with, if we have anaphylaxis, okay. So what is the usual picture under anesthesia for anaphylaxis?
Tachycardia, hypotension.
Okay,
Tachycardia with hypotension.
okay,
Urticaria, skin rashes,
okay.
bronchospasm.
Bronchospasm. Okay, so now usually this will be the usual features, and some of them will be masked by anesthesia. Okay, some of them will not be very clear. Okay, so usual bronchospasm will be evident as increased airway pressure. Am I right? Or sometimes, if, for example, just imagine a scenario: you started a case, and there this tachycardia may be because of the insane. Okay, because of any anesthetic medication you gave, not necessarily anaphylaxis. And usually there is a lag period where you are not able to identify. Okay, so that makes very tricky. Okay, that makes the scenario very tricky. Just a second, please. Okay, so like whenever you have any complication, okay, any unwanted thing, you have the approach will be journal, like your management approach or your differential diagnosis or your resuscitation usually will be generalized. Yes, there will be something specific to that complication, but usually whenever any critical incidents occurs, your approach should be generalized. And usually we use the word ABC. What do you mean by ABC? Like if we just get this example, as Dr. Lina, you told that just for example, anaphylaxis, what will be your approach for ABC?
Airway, squirrel airway. If patient not intubated, I will intubate 100% oxygen. Uh, good. بعدك
I
circulatory
will
support,
I
IV
will
fluid, adrenaline.
just a second. I will just give you an insight that would you like to intubate without any clear-cut reason, like any anaphylaxis? Would you like to intubate straight away?
According to the anaphylaxis, mild, moderate, severe.
Like according to the clinical picture you have. Okay.
Yes, yes,
So if you just try to generalize the approach of airway breathing circulation, maybe only putting oxygen mask with nasal
yes.
cannula or face mask,
According to the
maybe
patient's,
even
according to
clearing,
the patient's situation.
yes,
Yes,
even making the patient prop up, or just clearing the airway should be the initial thing. Okay. So just try to make up this mind that when you are talking about airway breathing circulation, if you are talking about airway and breathing, first of all, maybe jaw thrust and chin lift is part of A and B. Okay. Even clearing the airway, maybe the rescue you should be needing in any specific scenario. Of course, the overall clinical picture will correlate, will make the things correlated, but even clearing the airway by jaw thrust or chin lift, even putting airway, nasopharyngeal airway, or even putting placing nasal cannula or face mask with reservoir bag, or face mask with reservoir bag with non-rebreathing valve, or making BiPAP, CPAP, or mechanical ventilation. Like these are the steps. You will be having either of them. Okay. And what about circulation? Like, for example, you have anaphylaxis, you have in bronchospasm. Okay. So actually you are treating airway breathing, but maybe that for that treatment is in that scenario, you are just trying to give, for example, epinephrine. Okay. Epinephrine is treating actually airway breathing as well, in the form of making the because of the cause in anaphylaxis is the release of inflammatory mediators. And one more thing, which will be side by side with ABC. Okay. What will be that thing in addition to
bronchodilator, like
no,
beta
no,
agonist.
sorry. No, I'm sorry. I'm just trying to make your thinking towards something else. The generalized thing, in addition to airway breathing circulation, always you will be doing call for help. Okay. You will be doing a maneuver, which will be the word stop. The word stop will be there for everything. It may be stopping the surgeon. It may be stopping some inciting agent. It may be stopping some medication. It may be stopping any epidural infusion. Yeah, whatever. Okay. Like in case of malignant hypothermia, you are stopping the inhalational agents. In case of local anesthesia toxicity, you are stopping the local anesthetic. In case of any suspected anaphylaxis, you are stopping that culprit medication. Okay. So remember the word call for help and stop in addition to airway breathing circulation. Just think that, do you want to stop something? Like, for example, if you have a bradycardia at the time of laparoscopic insufflation, if the trend is going down, and you are picking that, you will suddenly stop the surgeon to deflate. Like, you will be asking the surgeon to deflate. So this will be one of the management. So similar is true for oculocardiac reflex. Similar is true for example, if venous air embolism occurs, you will immediately ask the surgeon to stop the surgery, infiltrate the area with saline, head down. Like, okay. So there will be certain responses which you will be doing immediately. If you are doing a laser surgery, okay, and suddenly there is a fire, so you will be stopping the oxygen. That is also stop. That will also come and stop. Generally, it looks weird, but in that emergency, you are doing other way around. Okay, you are actually stopping the oxygen instead of giving more oxygen. Here, if you make 100% oxygen, it will increase the problems. Okay, so this is, I'm just giving you an insight. Okay, so because we are not concentrating on any specific topic at the moment, I'm just giving you a concept of critical incidence. Just try to go back further. Is there any critical incidence related to there is a terminology called as never events in anesthesia? Have you heard of never events in anesthesia? What do you mean by never events in anesthesia? Have you heard of WHO surgical safety checklist? The sign in,
No.
check in, time out, sign out, which we do. This is also to stop a
I
critical.
believe, sir, never events are the ones which are totally avoidable and should never take place in the first place.
Okay, so that this critical incidence will be having a wrong sided surgery, wrong patient, okay, wrong procedure, anything wrong, okay, coming of wrong blood, wrong medication. So they remember this thing in your mind, like how to avoid the never events. Never events are including this thing, and usually WHO surgical safety checklist is to prevent the never events. Okay, you tally the patient ID, you tally the patient forms, you tally the patient file, you confirm there is a surgical and nursing team which is confirming the patient identity and the procedure and the site of the surgery. There is site marking being done. Okay, if you just come towards anesthesia side, you will have the correct concentrations, correct drug labeling. Okay, proper color coding. There is a specific color coding system of the anesthesia medications. Okay, so this is all which you do to avoid the never events. Okay, so never events are like this. Like for example, if you give a wrong medication. Okay, there was a flush. In place of flush, you flush some medication instead of normal saline. Someone just fill in normal saline instead, thinking without a label drug, without a label any syringe. The doctor thought that this is only saline and it is flushed, and that was some medication. Okay, so this is one. Similarly, wrong blood transfusion. This is something very, very lethal complication which you can face. Okay, so these were some words about never events. Okay, so now coming back to from where we started, airway, breathing, and circulation. Okay, so if we just go back towards that circulation part, what we can do for circulation. If we just consider about this same anaphylaxis, like we said that airway, we secure the airway even with any steps which I told you: nasal cannula, jaw thrust, clearing, and this oropharyngeal or nasopharyngeal airway, face mask, etc., use of bronchodilators, epinephrine. Okay, this is all for actually for airway and breathing. Okay, and you can add on some, if there is excessive secretions, you can add some this antisalagogue in that to just clear the airway. Now comes the circulation. So what should be the things which you should be thinking when you are talking about circulation? Yes, Abu Bakr. Placement of IV line. If IV line is not there, you are starting any fluid, whatever fluid is required, that is part of circulation. Okay, so in this, sorry, Abu Bakr, there is some problem in your signal, I think. I cannot hear you. Your voice is distorted.
Actually,
Uh,
sir, I'm doing right.
Okay, so in circulation, any medication, any vasopressor, okay? Usually in anaphylaxis, you are giving epinephrine, and later on, if it is needed, you are giving fluid, because there is redistribution because of release of inflammatory mediators. There is vasodilatation, there is pooling of blood, there is redistribution of fluid from the central compartment to the extracellular compartment, and there is relative hypovolemia which is occurring. Other component are the rashes, and other component are the features of bronchospasm, and any other like if it is any blood transfusion, hemolytic reaction, it may be also part of anaphylaxis. So that component will be in the form of hematuria, okay, and generalized patient may go in BIC, as patient may have ARDS. Okay, so these are all sequelae which you can have. So in the circulation, you can even the things related to maintenance of IV fluids, vasopressors, and even inotropes. Okay, what about D? What you do in D? Zishan?
I'm sorry, I just joined.
We are just trying to have a general approach to answer any question related to or answer or deal practically any critical incidents. Okay, so we discussed some of the never events which can occur, wrong drug administration, wrong and things like that. And just taking an example of anaphylaxis, we are just trying to make a generalized approach how to deal any critical incidents. Okay, so we talked about airway, breathing, and now comes circulation, and then D. What usually what is the component of D?
Disability.
Like how you define it? And if you just fit it, what would be the possible things which you are looking at?
In a critical event related to disability, is it means some kind of harm has happened to the patient or any of our staff.
Okay, what can like you are supporting something, okay? And also in D, I think the neurological system also is there. Yes, Abu Bakr?
Sir, I believe we'll be assessing the rest of the systems. Like we would like to know about the renal status, about the neurological status, and in this, whatever left will be assessing that in disability part.
And what about E? We use E as well.
That I'm not sure.
E is exposure. Am I right?
Yes, sir.
I think in D, the neurological status and any other system which may be involved will be there. Okay. So
Chair, urinary catheter for urine
yes,
output. Urine.
yes. Okay. Actually, there is so much background noise with your mic or something. If you are using headphones, you can try to remove the headphones. Maybe it will improve your sound. Okay, so actually I'm just trying to just give you an overview. Okay, so that's how you deal with it. Then you will be then another thing which you will be doing, that you will be doing some at the same time you are doing some resuscitation. The basic resuscitation, as we discuss, airway, breathing, circulation, neurological status. If, for example, if you just keep, because in different scenarios, there will be different things. Okay. Like if you have a patient with status epilepticus, so in addition to airway, breathing, circulation, for disability, you will be giving some anti-epileptics, okay, to control the seizures. That may be thiopentone, that may be midazolam, lorazepam, propofol, anything. So this will be the component, but usually you will be trying, and the next step will be that you will be doing the resuscitation, you will be doing the management, and you are doing the evaluation. Okay, you are trying to make up your mind. After the basic resuscitation, you will be thinking what is the possible cause, like for example, what for events leading to that critical incidents are important. Coexisting features, like for example, if there is only increased airway pressure, which may be anaphylaxis, which may be only a light anesthesia, which may be only kinking of the tube, or maybe only secretions, or any other thing, but it may be a feature of pulmonary embolism. But if it is pulmonary embolism, in addition to raised airway pressure, there will be something else coming in combo, like that maybe resistant hypoxia, there may be circulatory collapse. Okay, and there will be some other things which there will be in my will be supporting the diagnosis. That will be any patient factor or anesthetic factor or surgical factor which may be leading to it. Like there is a sequence of events which, if we just talk about embolism, so it may be thromboembolism, it may be amniotic fluid embolism, fat embolism, air embolism. So there will be some factors, like if there is a fracture, you will be thinking about in addition to all, even if you are having a fracture fixation going on, okay, under anesthesia, and you have ruled out everything, if the patient is getting tachycardic or hypotensive with raised airway pressure, you have to have the suspicion of embolism. Okay, so this is how you approach a patient. So there will be some combo deals which will be giving you an idea of what's happening. Okay, so if you have this general approach, and whenever you are answering any question, even in the practical conduct of the anesthesia, if you have this approach, it will be much easier for you to handle the situation as well as in the exam. And especially if someone who is going for some oral examination, like for example, some of the people who listen to it are the people who going for consultant evaluation in Saudi Arabia, or going for any final part of their fellowship exam. They want the general approach. Okay, so sometimes they are trying to check it out, whether what is your approach. Are you having the complete picture, or you are only one dimensional, trying to just reproduce the words written in any specific book? Okay, so that's how it goes. So in embolism, if we just talk about embolism, any embolism, air embolism, and except for air embolism, thromboembolism, fat embolism, and amniotic fluid embolism, the general approach will be almost the same. You will be doing the airway breathing circulation approach. You will be supporting the heart. You will be supporting the circulation. And in addition to that, if the patient is stabilized, if patient goes into cardiac arrest, you will have a ACLS protocol for the resuscitation. If it is before that, you are trying to, if it is clear cut, maybe you may needing anticoagulants or thrombolytics or things like that. Okay, that will be a little different in different, but general approach will be the same. In air embolism, what you will be doing in air embolism, you will be doing the head side down. You will be flooding the area. You will be using the bone bags. You will be avoiding any factor which can increase the air bubble, like for example, nitrous oxide or anything like that. Okay, so you will be just trying to and you will be trying to aspirate the air if you have CVP, or if you have the facility of T, you diagnose it very early and you are managing it accordingly. Okay, so that's how you will be dealing. Okay, similarly, a picture of embolism picture occurs also in another condition, bone cement syndrome. In the bone cement syndrome, you also have pictures which may be mimicking an embolism. So for that, because usually it is an anticipated thing, so you will be correcting, you will have a complete collaboration with the surgeon, and you are constantly in touch with the surgeon, and you know what they are doing. You can plan for the things which can avoid according surgical maneuvers. You can suggest, but it will be their decision. Like they can have distal hole to vent out the pressure, or from your side, which is more important, will be that you will be correcting any existing condition, like you will be correcting the hypovolemia, you will be correcting the hypotension. So your patient will be stabilized before they put the cement. Okay, so that if any unwanted event occurs, your patient is not lagging behind at that time. You are your patient is stable at that time before they do it. Okay, so almost a similar picture is related to tourniquet. Okay, when they are opening the tourniquet, the same thing can occur: redistribution of blood, release of inflammatory mediators leading to hypotension. So in similar way, you can anticipate and manage in a better way. Okay, that like before opening, you are correcting the existing problems, and you are mentally prepared for any sequelae. And of course, if there are some factors which can make your resuscitation difficult, you have to anticipate and correct accordingly. Okay, similar is which occurs in reperfusion after liver transplant, in the liver during the liver transplant, because it is, you can say, the similar response occurs in liver transplant, reperfusion, or aortic clamping and cross clamping. This almost the similar. There are a lot of similarities in these 3-4 conditions. Some of them are extra in this aortic clamping and cross clamping. You have to monitor the perfusion for kidneys and spinal cord. That is something else. But usually the hemodynamic sequelae are, some of them are the same. Okay. If you just like, this is the journal approach. Again, I repeat, airway, breathing, circulation, stopping something, stopping IV fluid, stopping the inciting event, stopping the blood, stopping epidural infusion, stopping any medication which you suspect, and call for help, resuscitation, management, and evaluation. And now you are trying to increase your reserve by giving more oxygen, by supporting the circulation, by fluids, by vasopressor, by ionotrope, and then this is general approach. Okay. Some words about aspiration thing, and some words about regional anesthesia, like local anesthesia complications. So local anesthesia complications, some of them are like people don't have clear concept about it. One of them is local anesthesia systemic toxicity. One is, for example, if you are giving epidural or spinal, high spinal, and total spinal. Okay, so I would like to ask Abu Bakr or any resident, if you want to answer, what is difference between high spinal and total spinal? Abu Bakr, would you like to tell?
Sir, will say total spinal when it was not intended to get into the subarachnoid space. We were attempting to give epidural, and it was accidentally delivered in the subarachnoid space. While higher spinal will be saying when our local anesthetic.
No, Abu Bakr, this is not the correct concept. Zishan, please correct it.
Sir, high spinal is when the patient's respiration is impaired. That means the spinal or drug has ascended up to the cervical spine, but not in the brainstem.
Zishan,
If the brainstem is involved, then it's total
I'm
spinal.
really disappointed. You are both of you are telling a wrong thing. Just try to rethink and answer again. What is total spinal and what is high spinal? Try again.
I believe
Zishan.
higher spinal is when.
Just a second, Abu Bakr.
there's
Just a second. Let Zishan please try.
I had this concept.
No. Listen, high spinal. What is difference between high spinal and total spinal? In which there is preservation of respiration.
Sir, the central respiratory drive is present in high spinal, But in total spinal, the central respiratory drive is gone because the brainstem is involved.
Not drive. It's not drive. Okay. It's not drive. It's paralysis. Drive is
Paralysis,
something
right.
else. Paralyzed because why? Why it is gone? It is not drive. It is paralysis because of involvement of which nerve?
So in high spinal, it's the phrenic nerve is involved.
No,
And
no.
Phrenic
That's
nerve.
what I was telling
in
you.
total spinal,
Yes, in total spinal, the cervical segments are involved and phrenic
Mhm.
nerve is gone. So that is total spinal. Okay. And high
Right.
spinal, which we label is at any level which you intended to get, and you
Mhm.
have a higher level than that. You say you label it as high spinal. Okay. For
Right.
example, you are giving epidural. What level you are wanted for labor analgesia?
T10 to
Okay, so if you are having level of blockade up to T5 even, you will say that this is high spinal level for that patient. Okay, but generally it is labeled when there are thoracic involvement, when cardio acceleratory fibers which are coming from T1 to T4, they are gone. The heart is now the vagus nerve is smiling. Okay, so the
Yes.
predominant parasympathetic tone will come, and now the heart will be having severe bradycardia, severe sympatholysis, there will be severe hypotension. And in that case, there will be respiratory, as you were saying, that because of hypoperfusion of the vital centers, there may be transient apnea. Okay. But if you correct the hypotension, that respiration will come back. But in total spinal, even if you correct hypotension, patient will not be able to breathe because phrenic nerve is gone, because cervical segments are involved, and now phrenic nerve is paralyzed and the patient is not able to breathe till the time that effect, for whatever reason, that effect will not. For example, if you have a spinal cord injury of high levels, patient will be on dependent on ventilation. Okay. And the patient will be having tracheostomy, and at the later on stage, there are phrenic nerve stimulator, diaphragmatic stimulator, which may be needed to get rid of ventilator. Otherwise, patient will remain dependent on ventilator forever. Okay. So this is just correct the concept. And the third thing related to regional anesthesia is, what is that? Abu Bakr, tell me, what is local anesthesia systemic toxicity?
So when we are exceeding the therapeutic window of the drug,
Try to be a little loud.
when we are crossing therapeutic dose of a drug and it is now producing systemic signs.
Okay. But what do you mean by therapeutic doses? Like, for
Uh,
example, what is the safe dose of bupivacaine?
With 3 mg per kg or 200 mg for an adult in total.
No. Please, Abu
Sorry,
Bakr.
2 milligram per kg.
I'm sorry.
2
2
milligram
per
per kg
kg.
for
2
Babacan.
mg 2 mg per
It
kg.
is
Sir.
2 milligram per kg. So it means, Abu Bakr, would you like to give 2 milligram per kg IV? It is safe. So why you are not giving 2
No,
milligram per kg IV? You
because
understand?
because it's cardiotoxic.
So cardiotoxics, then why are you giving inside any part of the body? It should cause toxicity. Even if you are injecting in spinal or epidural, it should block the heart as well. Why it does not do so? Why you are saying that this is safe dose?
Because it's absorbed slowly into the
Yes.
systemic circulation.
What is
If
the
it's given,
fate of the medication when wherever site? What is the site which from where after IV? Which is the site? This is MCQ. Which is the site which has the highest absorption?
Nerve muscle junction.
No, Dr. Humera. Your wrong answer hurts me a lot. Your wrong answer is
IV?
unacceptable. Yes, Ishan. Also, your wrong answer is not acceptable.
Sir, after IV, Injection.
After IV, what is the next, which place where you inject has the highest absorption?
Subcostal site.
Intercostal, yes. Okay, intercostal. Intercostal has the highest absorption. Okay, so actually this is the toxic level. And do anyone knows how much is the toxic blood levels of bupivacaine, which will be causing the toxicity? 5 microgram per ml. 5 microgram per ml, more than 5 microgram per ml will have the systemic toxicity. Okay, so if you give by any route, and because if, for example, if it is not the case, then why if you are giving any like epidural, it should not, if you are giving a very small dose, how can it is causing toxicity? Okay, so actually it is the number one, it is the blood toxic levels. It is also because there is a factory which is breaking it out, that is liver. Okay, the blood flow, and there are some other factors like protein binding and PK and everything, which is causing, which is use of vasoconstrictor, PK, not PK, and use of bicarb is for the onset of action, and absorption and duration of action, and the free drug, which is causing the problem. Okay, so please clear the concept. We just clear the concept about high spinal versus total spinal, and local anesthesia systemic toxicities from any route if drug is absorbed beyond the level which can create problem in the heart. Like if, for example, by mistake, if you give IV, even toxicity can occur in very small doses, because the blood levels may be achieved quickly and it will cause cardiac arrest. Okay, and what is difference between, you are giving lidocaine, majority of people now are familiar of use of lidocaine as IV infusion, or you are giving lidocaine in for treatment of arrhythmias. You are giving lidocaine for the treatment of for the blunting of stress response. We have discussed a number of times. Okay, so but usually what is difference in the if you are talking about last, what is difference in the appearance of sign symptoms between lidocaine and bupivacaine? Yes, Zishan.
Lidocaine, first of all, there are neurological signs first.
Neurological signs. Okay, so the levels at which the cardiac signs will occur is at higher level than neurological sign, while for bupivacaine maybe cardiac signs will appear earlier. Okay, so this is how it happens. So please correct the concept. That's why I humbly request all of you to come out of books. You don't know, you have wrong concept or you have misconcept, because the books will never give you the correct concept if you are not discussing them. Okay, that's believe me, I don't have the correct concept of total spinal and high spinal. I corrected it very later in my career. Okay, so that's why that's why I'm after all you people to have discussion. If you have a clear concept, you will be able to answer MCQs as well. Majority of people don't like to join us because they are thinking that we are talking something only which are about Viva. It's not like that. If you have the clear concept, then you will be able to answer the MCQs as well. Okay, so like that's why these critical incidents related to regional anesthesia should have a concept. The hypotension which occurs after spinal or epidural is because of, Zishan, because of what thing? Why hypotension occurs?
So peripheral vasodilatation.
Peripheral vasodilatation because of
Loss of sympathetic tone.
yes, sympatholysis. Okay, because of sympathectomy, because of loss of sympathetic tone. So that is the reason for hypotension. And what else? So some words about aspiration. I hope you are clear about this concept of complication related to regional anesthesia. Hypotension occurs, or usually this is the thing which occurs after regional anesthesia. Even if you have given peripheral nerve block, immediate actions will be complication related to regional anesthesia is also incomplete, wrong-sided block, failure. Okay. You need to top up, or another thing which will be there in complication, IV injection, hematoma. Okay. And what else can occur after regional anesthesia? Incomplete, failure, sparing of certain nerves. Okay. If you have given any peripheral nerve block, sparing occurs. This is also a complication. Okay. The drug is absorbed in the systemic side. This is a complication. There are certain nerve blocks in which drug is traveling to the neuroaxial compartment. This is also a complication. Okay. And there are certain blocks in which you can rupture some viscera or some other structure. That is also part of it. Like example for it, if you are giving femoral nerve block and you have gone beyond the inguinal area, you can enter the gut, you can hit the peritoneum. Okay. You are doing this one tab block and you puncture the peritoneum and you injure some viscera. So this is also a complication. So you should be knowing that sparing is one complication, incomplete or failure is also complication, vascular injection is also complication. So these are the complications which you can face related to regional anesthesia. Okay. So I will just have few words about aspiration. So how to prevent aspiration? You have to decrease the volume, you have to increase the pH, and you have to avoid, you have to do the rapid sequence induction. You can have the proper NPO. In deflating the stomach is not a good choice, but you can do in certain conditions. But usually when you are deflating, there is more chances of aspiration because of loss of physiological sphincter tone of esophageal, lower esophageal sphincter tone. Okay. And intragastric pressures are more important, which also occurs with the dose of suxamethonium even. Okay. So that is itself is a problem that can cause some problem as well. Okay. And while ventilating, if you are giving high airway pressures and there is air going in the stomach, that is also creating a risk factor for aspiration. There will be some, like again, surgical factors, anesthetic factors, and patient factors. You should always classify your causes in that way. Okay. So I just wanted to have an overview about how to manage general approach for complications. Okay. And there are so many other complications which can occur. Like if you are talking about anesthesia, even pneumothorax. Yes, we can talk about pneumothorax, that in pneumothorax there will be like how to manage tension pneumothorax. Zishan, how would you explain?
Tension pneumothorax, first of all, airway breathing and circulation, give 100% oxygen to the patient, maintain IV access, and we have to do the thoracostomy in the second intercostal, needle thoracostomy in the second intercostal space, mid-clavicular line. And then definitive treatment is through chest tube insertion in the anterior axillary line in the fifth intercostal space.
Okay. Any other thing other than this thing which you have told? There is one thing you have missed, which is related to the cause, why it happened. Okay.
Right.
So you will be looking into consideration the cause which lead to the event. Okay. So it may be fracture, it may be like anything. The reason may be anything. Okay. Maybe pneumothorax occur because you were ventilating at high pressures in a patient with the emphysematous bulla and the bulla rupture. I'm just giving you example. So whenever you are telling something, try to treat immediate thing and try to go back to treat the cause. Okay. Any arrhythmias occur. So arrhythmias, immediately you are treating it as per ACLS protocol. You are treating it as a SVT or VT or shockable rhythm or non-shockable rhythm according to the hemodynamics, according to the clinical condition. But at the end of the day, maybe you are treating the ischemia later on, or you are treating any electrolyte imbalance. Okay. Or you are treating, for example, benign PVCs. The again anesthetic factors may be the tube touching the carina, light plane of anesthesia, then electrolyte imbalance, or any patient factor like patient already has some ischemic heart disease or sepsis or anything like that. So you, whenever you are having any complication, you have to consider it the basic things, and you will be targeting accordingly. Okay. Some words about myocardial oxygen demand supply ratio leading to ischemia, because our whatever anesthesia we are giving, our main aim is to keep the perfusion of the vital organ systems. Okay. So if you are dealing with this one, any factor in which heart is at load, like, or there is reduced hemoglobin concentration, for example, actually you just have to avoid further factors which will be leading to stress, increase oxygen demand, and decrease supply. Okay. So this is the general principle, and then you will be involving certain teams. You can have different teams, like for example, any cardiovascular problem, you will be involving the cardiologist. Okay. And in certain complication, you will be involving the intervention if radiologist. Okay. You will be considering involvement of surgeon or things like that. Okay. So the aim of our discussion was to approach how to approach a critical incidence. Okay. And what are the journal maneuvers which you will be doing, and then how will you resuscitate, how will you will be further digging into the cause, you will be taking some history, and then you will be managing them. Okay. So in this discussion we have covered some complications that related to anesthesia. Maybe um, uh, any question from your side? Okay, so we will discuss some other topic in next discussion, inshallah. Okay, thank you very much.
Sir?
Yes, Ishan.
The thing you were telling about total spinal, that
Yes.
it's not recovered soon. What I've read in the article and in the books also, that if total spinal has occurred, we just have to sedate and ventilate the patient for a few hours, maybe till the time the drug's effect has passed away. Isn't
Actually,
it
total
so?
spinal. No, sorry. I will just. I understand your question. Maybe I will answer that. If, for example, if it is a correctable cause or manageable cause, then it will occur. If it is a spinal cord injury, that it is actually total spinal. The picture is also like total spinal. In that scenario, patient will not be able to come back. Okay. And for
Right,
example,
but
total.
due to bupivacaine, due to
Yes,
our local
bupivacaine, of
anesthetic,
course.
there is total.
Of course, bupivacaine will come back. Of course. That like high spinal, for example, usually when we give spinal and patient became going in arrest, you see in our hospitals, there are certain time when you have given a higher dose, or for any good reason there is severe hypotension and patient went into cardiac arrest or unconscious. Actually, this is correctable. Okay. Because in total spinal you need to ventilate and keep the patient ventilated till the effect will be finishing. In other case, the difference which I was telling Zishan, that in high spinal, if you correct the hypotension, the respiration will come back. In other way around, till the time the effect will not finish, phrenic nerve paralysis, till the time it does not come back, reversible or reversible. Okay. Till the time you need to ventilate, patient will not be able to
come back on ventilation only by correction of hypotension. Okay, so that's what your concern and your point is valid. Okay, so maybe
Yes,
I
sir.
just
Yeah,
went
I got
more in.
scared.
Yes, I
I
went
got
more into
scared
the
there.
spinal cord injury. Okay.
Right. Sir.
Okay, thank you very much. And we will discuss some other topic later on. Okay, Assalamu alaikum.